Good morning. Good morning, everyone, ladies and gentlemen. My name is Giuseppe Tarantini, and I do really feel the privilege today
Gibst du mir ein Blatt
to
Papier
share
bitte,
and kick off
zusammengefaltet, bitte?
this
Leeres.
webinar that is entitled How Should We Use Transcatheter Tricuspid Valve Repair to Treat Patients with Tricuspid Regurgitation. I think that this webinar promises to be very exciting for several reasons. First of all, we're going to discuss about tricuspid. It is a very complex valve system. It is actually also the so-called the most forgotten or sometimes the most refused valve in terms of treatment. Secondly, we will discuss about innovative catheter-based technology with the main and specific focus on PASCAL systems. Then we will do that by means of a live case that will be held in Munich and led by Jörg Hausleiter. And I will be helped out through this session by the help of a real expert and key opinion leader that are Rudolf Volker, that is with us, and Rebecca Ann. So having said that, please give me the first slide just to introduce the session objective of this webinar. Can I have the first slide, please? Put on the screen. Next one.
Next one.
Okay, please, to all the people that is connected, that I would like to encourage to be fully engaged from the very early beginning and to post questions, and that's we will discuss with our experts and with Jörg during the case. But please participate and attend this webinar if you wanted to appreciate the potential clinical impact of the earlier treatment of tricuspid regurg, to understand how transcatheter tricuspid valve repair devices may impact on individual patient outcome. And finally, to participate in this live case demonstration, use the PASCAL repair system for transcatheter treatment of tricuspid regurg. Having said that, I think we can get started with the real, most important part of this webinar, that is the live case. And in doing that, I will hand over to Jörg. Please, Jörg.
Yes, thank you. Thank you very much, Giuseppe. Very nice and warm welcome to everybody outside in these Corona times. Here from Munich, from the Heart Cath Lab 2, from the Ludwig Maximilians University 2. Today we will show you a case with severe tricuspid regurgitation and how we are treating those patients today. With me, I would like to present you my team. On my right side is Daniel Braun, who's helping me in this procedure, and at the echo is Professor Michael Neubauer, who will also explain you in very detailed the tricuspid anatomy and also how we're going to treat these patients. With this, I would hand over now to Daniel, who will present the patient to you. Maybe we can go back to the slides, please. Okay.
So today we're gonna treat a 60-year-old male patient which suffers from right heart failure. The patient had recurrent heart failure hospitalizations. The patient suffers from chronic atrial fibrillation, has a reduced kidney function, a history of pulmonary embolism, suffers from diabetes and cirrhosis cardiac. The patient is currently on optimal medical therapy with a aldosterone receptor, with adequate doses of aldosterone receptor antagonist and loop diuretics. And under this medication, he is currently in a compensated clinical state. Concerning lab values, the patient has chronic renal insufficiency with a glomerular filtration rate of 36 milliliter per minute. The liver values are normal except of a slightly elevated GTT value. On the right side, you can see a chest X-ray where you can see globally enlarged heart and signs of pulmonary congestion. We assessed the surgical risk of this patient using the LePar risk score, which is currently the only score which evaluates the risk for isolated tricuspid surgery. And the patient is older than 70 years old. I hope you can see this, which adds 3 points to the risk score. And the patient is an NYJ class 3, which adds additional 2 points to the risk score. So this clinical risk score of 5 corresponds to a predicted mortality, operative mortality of 7%, and a predicted morbidity of 26%. And this correlates well to the Euroscore 2 of 6.8%. Here you can see the coronary angiography, which was performed in the referring hospital. And as you can see, there are no coronary artery stenosis. The colleagues performed a right heart catheterization and reported a systolic pulmonary artery pressure of 42 millimeters of mercury and a ventricularized RA pressure curve. Weiter. Here you can see on the left side the apical 4-chamber view with preserved left ventricular ejection fraction and mild mitral regurgitation. On the right side, a dilated right ventricle with a slightly reduced right ventricular ejection fraction, numerically almost normal. And here you can see on the left side a severe functional tricuspid regurgitation in the transthoracic view. On the right side, the corresponding transesophageal view with a severe functional tricuspid regurgitation, which is predominantly central and reaches into the anteroseptal commissure. We usually do for the anatomic, to evaluate the anatomic feasibility, a sweep from the anteroseptal to the posteroseptal commissure. And as you can see, there is no large coaptation gap, which precludes device implantation. And here you can see a transgastric view without and with color. And as you can see, there is a severe central tricuspid regurgitation, which reaches predominantly into the anteroseptal commissure.
Yes. It's one more. So if we summarize this, as you see here, again, we have this very old patient, 86 years old, right heart failure, recent heart failure hospitalizations. You see the reduced kidney and liver function and the history of pulmonary embolism, which might also add some risk for surgery. As you have seen, although the risk scores are not really calibrated for isolated tricuspid surgery, especially the Euroscore 2, at least still we have a risk score for mortality during surgery of around 7%. He's moderate frail. He's due to this elevated age. You have seen the elevated PA pressure, and I'm going to show you a current right heart catheterization in a minute. No coronary artery disease and no significant aortic and mitral valve disease. And this is what we now discussed with our cardiovascular surgeons. And what we want to discuss with you, what do you think about these patients? How would you handle such a patient in Italy and in Bad Oeynhausen? And perhaps if Becky is also with us in the meantime in the US.
Okay, thank you. This is the case summary to share with the attendees. Just to sum up, we have a very severe tricuspid regurgitation without a left-sided heart valve disease. So we have a kind of standalone tricuspid disease. We have a symptomatic patient. We don't have an extremely severe right ventricular dysfunction, and we don't have, by the data before the current cut, we don't have invasive data that tell us that there is a very severe pulmonary hypertension. So based on the previous guidelines, we know that these patients might need a kind of intervention at the level of the tricuspid. But the point, and this is the first question to Rudolf, is in the previous guidelines that are going to be updated the next year, we don't have any line, any suggestions related to the transcatheter approach in this patient, because the only suggestion is to do surgery. But now we have new data that are encouraging and promising also in favor of the use of transcatheter approach in patients with high surgical risk like the patient that's been presented today. So my question is, when you discuss with the patient, with the family, this case about the different possibility, therapeutic possibility, the point is, what can they expect from this procedure in terms of periprocedural feasibility, efficacy, mortality, morbidity? So Rudolf, what is your thinking about that?
Yeah. Well, I think, thank you very much. This was an excellent summary of the patient, and I would totally agree that, I mean, even if it wasn't for the tricuspid valve, this would not be a surgical patient. I think we all agree on that. The question, what is important, or what can we confer to these patients is really important. And we're still at an early stage, but nevertheless, we have data available. We have data from the Triluminate trial. We have data from the PASCAL device from the early feasibility study, and also some data from compassionate use. And what we see throughout all these data is that we can perform this procedure with a very high efficiency. So procedural success is 100%. So this is, I think, very important at this early stage. Safety, especially if we compare it to cardiac surgery, is very high. We have complication rates, major adverse event rates at 6 months of only 6% compared to about 10% in hospital mortality after isolated tricuspid surgery. So this is also very important. And I think this is particularly important for these patients. We have improvements in symptoms. We have in Triluminate, for example, we had at baseline 25% of patients in New York Heart Association 2, only 25%. And after 30 days, this increased to 80% in New York Heart Association 2. So this is really something that patients can expect. Nevertheless, I think it's also important to explain them that our efficiency with regard to eliminating tricuspid regurgitation is still improvable, I would say. It's about 50% where we can reach TR2 or less. And this is something that I think patients have to know, and also the referring physicians have to learn that at this stage, this is what we can achieve. This does not mean that we cannot get better. I think we will be able to get better, but even with this reduction, we get a good clinical effect.
Thank you, Rudolf, for this important and bright review. Before handing over to Jorge, because I have a question also for him, I would like for the audience just to, because probably not all the people are expert like you, Rudolf. So the first concept, correct me if I'm wrong, the first concept is that this patient is amenable for a leaflet approach, because we don't have a gap, a significant gap between the leaflets that's impede to go for a repair. So the first choice might be a leaflet approach. The discussion is about TriClip or PASCAL, and we can discuss about this a little bit more. Now I see, and I say hello also to Becky for joining us. The second point is the feasibility is almost 100%, and the procedural success is more than 80%. Whatever is the device that you use in terms of repair, but the condition, the precondition that is very important is the value of the images, because you need to have a very clear and very accurate picture by echo to trust when you do this procedure. It is not easy if you don't see clearly what you're going to grasp. This is the first important message to share with the audience. So before, turning over to Becky, I would like to ask to Jörg, how should the patient be prepared before the procedure? Because the setup of the room is pretty copy and paste with the mitral clip. We don't have to change too many things in the room. But what about
Yes.
preparation of the patient?
Yes, Giuseppe, you're absolutely right. The room setup is more or less the same as we use it for mitral clip or a mitral intervention. The only specific detail about this room is, and you will see this in a couple of minutes, is that we are able to tilt the table, meaning that we can tilt the table so that the head is higher than the feet, so that we have a venous pooling in the legs, which will help us to reduce the gap size in the tricuspid valve in a few minutes. But otherwise, the room setup is all identical in the cath lab as we do it for the mitral procedures.
The other concept for the audience is that this patient was already in full medical therapy. So the point is that this procedure again are mainly focused on the heart team discussion that include the surgeon, okay, the interventional echocardiographer, that is a total different animal from the simple echocardiographer. And I would like to involve in the discussion Becky in this regard, because making a transthoracic echo to evaluate tricuspid is a total different story to make an interventional echocardiography view to perform this procedure. Becky, can you discuss a little bit more about this difference for the audience?
Yeah, I mean, I think the one thing that we've learned is that we've developed these protocols for screening that we, and listen, Jörg and Michael are really key players in this arena where we can actually have a set protocol of imaging in order to plan the procedure and determine and predict the success of the procedure. And so it's truly important to understand the nuances of the transesophageal screening echo, in which we end up using a lot of the what we call the tricuspid commissural view, but also the transgastric views, which allow us to not only identify the number of leaflets, which are frequently variable, but also the location of the regurgitant orifice. And this is really key to all the planning, and it is indeed extraordinarily different from, because of the heavy dependence on an understanding of the tricuspid anatomy, but very different from just a routine echo, routine transesophageal. We have actually created a new imaging level that we use, which is the deep esophageal view, which has ended up being very useful, particularly in those patients that come to us that have already had left-sided heart surgery.
But maybe we should take now the opportunity just to go into the current imaging and so that we can discuss how the tricuspid valve looks like in this patient. So we're doing a little change of our schedule, and I would like to hand over now to Michael so that he's going to show you the current echo cardiogram of those patients. Can we go live with the echo, please?
Yes.
Yes.
Perfect.
Am I live? Yes.
Yes,
probably.
now you're live.
This is the tricuspid valve of the patient today from a deep esophageal view. Deep esophageal view means that you don't have the atrial septum in front of you. This is basically between the atrial septum and the transgastric transition. You get the deep esophageal view, and this is the basic anatomy in this patient. 1 second. Is here. We usually start with an intercommissural view from an esophageal window, and that's what you see here. This gives you an impression of the valve, usually fairly good. impression, and you can assess from this view also the amount of regurgitation, and you actually can assess where this regurgitation happens. You can see it's in between the anterior and the septal leaflet, and it extends down to the center of the valve. I'll show you in a second that the papillary muscle is here, so the anterior leaflet ends in this region. This is a very important step. That's what we call a sweep through the tricuspid valve. We start on either end. Usually we start at the aortic end of the valve. The aorta is here in this area, as you know, and we start from here and do a very slow sweep over the valve. And what you can see here is that the anterior leaflet, this is this part here, has virtually no tenting, I would say. But it has some sclerosation, probably related to the pathology of the valve. It seems to be a little hyperdense here. And if you continue looking at this sweep from the aortic to the posterior commissure, you can appreciate the coaptation gaps of the valve, which is best seen here in the middle of the valve. You see a coaptation gap here, where there is actually the most of the regurgitation. In this sweep, you can also see the papillary muscle, and I want to alert you to this. Here is the papillary muscle. The anterior papillary muscle, and this is the end of the anterior leaflet and the beginning of the posterior leaflet, just to alert you that you can learn a lot from this intercommissural and cross-plane view. If you are lucky, you can have a 3D image of the valve like here, and you see that it's quite a standard tricuspid valve. Here's the aortic valve. In this area, we also turn it down to 5 o'clock around. Here is the septal leaflet, anterior leaflet. Here is a small commissural extra lobe, and you have the posterior leaflet. Same thing again, and in addition here, the regurgitation in 3D imaging. Here, it's easier to appreciate that the aortic valve is down here in this area. Now, a transgastric view, which is very important to understand the anatomy of the valve. And again, the aortic commissure is down here. This is the septum to the left ventricle, anterior leaflet here. Here is a small commissural leaflet, posterior leaflet. And you can also appreciate here where the convergence zone or the vena contractor zone is. That's what we try to do at the tip of the leaflets. So you can see that the regurgitation is between the anterior and the septal leaflet, and it extends to the center of the valve here. That was where the largest coaptation gap has been seen. Frequently, it's helpful to have both the standard view and the color view on a single image to better understand where is regurgitation and where are the leaflets.
Perfect. So Becky, do you have any comments about the imaging?
Well, it's absolutely beautiful imaging, but I do think that it helps you plan the procedure. The regurgitation is all along the septal leaflet, and as we know, that lateral wall tends to dilate out. The septum stays relatively stable, and that's why we see that the gap all along the entire commissure of the septal leaflet. The transgastric view suggests that there's a little bit more between this anterior and the septal leaflet, but in all honesty, I'm not sure that you can get away with not treating the posterior septal gap as well. There's a fair amount of leak posteriorly as well.
I absolutely agree. This is also what we thought about, and we can perhaps discuss about strategy for PASCAL placement also a little bit later. Perhaps I would suggest, Giuseppe.
Jorg, 1 second. There are
Sure.
two questions from the attendees. The first one is, what about the etiology of this tricuspid regurgitation? And just to be clear, this is a functional tricuspid regurgitation. Becky, correct me if I'm wrong. And the second point is, please restate the indication of the procedure. As I told you before, the indication in this case is severe tricuspid regurgitation, symptomatic on top of full medical therapy in a context of a patient without severe, extremely severe pulmonary hypertension or extremely severe right ventricular dysfunction. So this patient, this is the right time point to intervene in this kind of patient to avoid the progression of right ventricular dysfunction. Okay. I think you can go on with the case because the time is running.
Yeah, the time is absolutely, the time is running. So perhaps we can show you briefly the right heart cath, which we have done already. Anita, can you show us the PA or the PC pressure? So can we show the hemodynamics, the other monitor, the other hemodynamic monitor? We have two. This is the one. This is the pulmonary wedge pressure, which we have measured before. You see this is a scale of 40. So we have a mean pulmonary wedge pressure of 17. No significant V wave, which is correlating well with the trivial mitral regurgitation, which we have seen before. Now we go to the pulmonary artery pressure, the other one, the pulmonary artery pressure, which is, I think, interesting. Again, this is the scale of 40. You see that we had a systolic pulmonary artery pressure of 46, diastolic of 18. The mean is 25. Fits very well to the previous right heart cath, which has been done in the referring hospital. And now we go to the right atrial pressure. This is also shown here. So we have a right atrial V wave, which is around 20. In the current, and I'll show you this in a second, it is a little 10, slightly higher, and it is a really ventricularized right atrial pressure, as we can see. We did also a cardiac output assessment. The cardiac output was 6 liters per minute. So we have not a significant pulmonary artery hypertension. And due to this difference of wedge pressure to pulmonary artery pressure, which is just around 8 millimeters of mercury divided by the cardiac output of 6, the pulmonary vascular resistance is around 1 to 2 Wood units. So we have significant, we have a slight pulmonary arterial hypertension, but all post-capillary, no pre-capillary pulmonary hypertension, despite the history of 2 previous pulmonary embolisms.
Okay, I think, Georgi, you have to start working. In the meanwhile,
yes.
we try to discuss it. I think it's difficult to complete the tricuspid procedure in 20 minutes. So I think you have to move fast forward. In the meanwhile, I would like to ask to Rudolf, what do you think? What about the invasive measurements? What can tell us, and mostly, what are the things that we have to look invasively that may contraindicate this intervention?
Giuseppe, just 1 second. Before you go into the detailed discussions, let me show you briefly what I have done so that perhaps the audience can follow the echo while we are treating the patient. Can we go to the echo, please, on the webinar? Yes. So what you see here in the echo is the deep transesophageal view, and we have selected a PASCAL device for the treatment of this tricuspid regurgitation. It is still in the right atrium before the tricuspid valve, and what you see here is that the PASCAL device has the option that we can work on the clasp separately. So here you see the anterior clasp when it goes down, and this is the posterior. So we can grasp the leaflets independently and one after each other if we need to do this. And what I will do now in the next few minutes is that we're going to go into the right ventricle and we're going to grasp now the anterior and the septal leaflet. Okay?
Okay, perfect. For the audience, because not all the people are experts like all of you, the point is that with tricuspid, it is a very complex valve system. We have more dense cord there. We have thin leaflets, variable leaflets, because you might have also deep clefts or variable folds, and then you might have also large annuli. And the advantage in this case of the PASCAL might be related to the fact that you may reduce the stress on the leaflets. You might increase, because of the spacer that you have inside in the PASCAL, you might reduce the risk to have an orifice area that is very small during diastole. There is the opportunity of the independent grasp, as Jörg have shown to you. And finally, there is another thing that is very important for the operator, that in case you are not happy with your position, etc., you may reduce the entanglement in tricuspid cord and subvalvular apparatus, because you have the opportunity to elongate the system. This is not the case of the mitral system, or the triclip, for instance. So these are some, technical, theoretical advantage that might, get the operator to choose in some anatomies PASCAL instead of
Michael, lass uns hier
oriented devices. I see
nach
that
oben gehen, oder?
Bist du drunter?
Ja.
Bist du so weit weg?
Okay, now please comment what you're doing operatively.
So now here we're in the transgastric view. You see that we are orientated with the PASCAL in this open mode, so that the PASCAL is 90 degrees to the line of coaptation between the anterior and the septal leaflet. And now I think what we're going to do is that we're going to go back to the deep esophageal view, and then we're going to try to grasp the anterior leaflet and either the septal leaflet at the same time, or one after each other.
Okay, sometimes, Rudolf, it is not really predictable that we are able to succeed at the first attempt. So in the case for the audience, if you can comment on that, if you're not able to grasp simultaneously, or even in a two-step, at that point of the commissure, we can go a little bit more deep in the commissure just to get closer the septal and the anterior leaflet, and to have a much more likelihood to succeed with the second PASCAL a little bit more central. What is your experience in this regard?
I mean, absolutely. I think it's totally feasible in the tricuspid valve. I mean, the opening area is usually very large, so we do not have to be as restrictive as on the mitral side. So the sipping technique is something that can be considered. Also, clearly, I mean, Jörg mentioned this, by tilting the table or by, of the patient, you can also achieve a lot in order to be able to do this first valve, as the RV reacts very sensitive to volume changes. So that's really something that's very important in order to achieve success.
Thank you. Please, could you go with a large screen, focus on Nico, because this is a very central part of this live case.
Ist relativ weit oben jetzt.
We have also
Ich habe ein bisschen aufgeschoben, ja.
So we can discuss a little bit about the position.
Okay, jetzt bist du weiter unten.
Probably you have the septal leaflet, but the anterior one is really touched. It's not.
We have now tried to grasp the anterior leaflet, as you have seen, and now we would try to swing over to grasp the septal leaflet. Which is the upper leaflet there.
Yes, see.
I think it's in right now.
Nee.
Is
Maybe
it
not.
your default strategy to start clipping just one leaflet and then to clip at the second stage the other one, or the first
Das ist
attempt
drin.
to grasp simultaneously two of them?
Well, it really depends. Very often we're using this independent grasping technique, which helps us to focus on one leaflet after the other. And if you're careful and if you're not pulling too much on the leaflets, I think it will not distort the valve too much. Which is always a small risk, of course, when you do this independent grasping. So, but before we close now the PASCAL, we will do a check of the leaflet insertion as well as a transgastric view to confirm that we are still in the same place as where we wanted to be. By fluoroscopy, at least, the PASCAL has not really changed its position. Maybe we are a little bit too clockwise orientated in this view, so maybe we're going to release the septal leaflet here again, and we'll try to grasp the septal leaflet in a more central part.
Actually, on my side, I believe that the PASCAL is not oriented properly. Probably you need to go counterclockwise a little bit.
That's what I'm just said, yes.
Septal. Yeah, this is
that's beautiful.
Soll ich hochgehen?
Yeah.
Too commissural probably, but if you have both of them, it's gonna be okay.
Ah, Entschuldigung.
This is the inflow and outflow projection. Okay, explain. Sometimes when we have some doubts, Victor and Rebecca, we
Wanderst wieder nach oben.
used to grasp in transgastric, just to be sure about the orientation of the PASCAL. What do you think in this regard?
Yeah, we've taken to using, if we need to use the transgastric as our grasping, because of the orientation, you won't actually get to see, you'll get to see the leaflets move into the arms of the device, but you won't actually get to see the length of the leaflet in. But from a transgastric, if you use the live 3D multiplanar reconstruction, we frequently do that, and then rotate around just so you can see the actual arms of the device and the length of the leaflet being captured. So I agree with you that sometimes the transgastric is the best, but in order to see the leaflet length being grabbed, we use multiplanar reconstruction from that view.
Yes.
This is beautifully imaged, though.
Yes. The images are really remarkable because
it's really beautiful.
It's not frequent to see a picture like this.
But it's not that easy actually to grasp the leaflets because the right atrium, as we have seen,
is named tricuspid. This is just because of that, because this is a very important message to the audience, that you need to be a little bit patient and you need to be very keen on putting together pictures, knowledge and
Gleich gehen wir noch ein bisschen zentraler. Was meinst du?
So you might be so close to the commissure that the septal leaflet's a little shorter than you think.
Yeah, that's why we just discussed. We think that we're going to try to go a little bit more central to the valve. Also with the anterior leaflet. So I'm releasing now both, and maybe we need to go
I think you can go with transgast in this view to make, yeah, this is a little bit better. If you go a little bit more subtle,
No.
the orientation is,
So I'm extending the device so I get out of the right ventricle so that we're safe and not too entangled.
okay,
And
this
we
is,
will start all over.
Yeah, it looks like you look at the commissure, you have so many cord in that commissure,
Yeah,
right? I think
many cords.
this is
You're absolutely right.
from the audience. So when you feel your PASCAL that is stuck or the movement that is not free inside the valve and you have a lot of cord like this case, it's better to elongate and to restart.
But I think you're right, Giuseppe, about the elongation function of the device. It is just a beautiful thing. So often we can get caught right in that commissure. You see how many cordi. But the elongation, he came out right away and didn't get, entangled at all. And we found that it's extraordinarily useful. And then you can really precisely position these devices such that the early feasibility trial showed that the mean number of devices was under 2. I think in part because we can so precisely reposition.
Okay, geht's nach oben?
Nach oben?
Ja. Vielleicht kriegen wir doch beide gleichzeitig drauf, simultan.
Okay, now the position is a little bit different, it's more central, it is clear. So less anterior, less commissure.
Yeah.
The anterior is on.
Yeah.
Just machen wir runter, anterior. So we press the anterior now at this position. And probably the septal is hopefully easier to grasp in this position as well because it's longer.
Bist du richtig offen?
Probably there is some problem with the orientation. But counterclockwise a little bit probably would be better. A little bit.
It's too much counterclockwise, so we have to check.
Yes.
It's rolling in.
Yeah, it's rolling in. Yeah.
Jetzt ist drauf.
Now it's on.
Oh, here.
Now we're going to grasp this.
Try to grab this. Yes.
And now we're going to check again that in the transgastric view the location. And now we're in this, at least in the orientation as we want it to be.
Far better.
Much better.
Yeah, much better than before, and we're more central. So maybe we go back now into the
what type of PASCAL you selected?
We selected a PASCAL ACE, which is the smaller device, which helps us, especially in those patients as this one, where we have very dense chordae to get under the leaflets.
Okay, so
I would
PASCAL ACE for the audience is a little bit, thinner than the normal and classic PASCAL that permit to be a little bit more gentle during the grasping of these really, thin and variable leaflets.
And now what you have seen in the last few seconds is I slowly closed the PASCAL in this position.
Yes.
We had some tension on the anterior as well as the septal leaflet. And now we will check in a few seconds the color. What is important for us is this distance between the PASCAL and the anteroseptal commissure, because we would like to keep this large opening between the aorta and this device.
Okay. So please, Becky, could you comment about, the amount of tissue, the consideration that you do to say to the operator, okay, I think it's fine, we can detach the system?
Yeah, I mean, it's really important to, lost my internet for a sec. It's really important to see the leaflets go into the arms of the device. And if you can get at least 7 millimeters in there, you usually feel fairly safe. Obviously, if you have a little bit more, it's even safer. So 7 to 9 millimeters in. The thing about the ACE is also that it's got a much thinner spacer. And therefore, you can see how beautiful the imaging is. I mean, obviously, Michael's an expert, but with the P10, the spacer is quite large and sometimes causes a lot of acoustic shadowing of that anterior grasping arm. And here, he had no shadowing. It's just a beautiful example of the imaging of this ACE device. So sometimes we'll also measure the leaflet lengths at the location of the grasp before we grasp, and then what's left on the outside of the device after the grasp. But this looks like, he's gotten a fair amount.
Oh, there's still some TR left between the anterior and in the anteroceptor line of coaptation there, where the cursor is right now. It is reduced, but we have a lot of redundant tissue.
It's splitted.
It's split.
It's split.
We're trying to evaluate the leaflet insertion, really to be sure that we have enough leaflets in the device. And we see this slow sweep from the anteroceptor line of coaptation into the device. Michael, what do you think? Do we have enough anterior leaflet, or?
Have you closed completely the PASCAL or not?
Yes, it's completely closed. What is
the images that we have, over the PASCAL? That seems to be, what is it?
Pardon me? What kind of image?
The clotting time. The activated clotting time.
The ACT, it was 316. This is what you see above the device. Are the how you call this, in English, the lines which actuate the clasps. These are not thrombi, but these are
the wires.
The wires.
I have a question from the audience. If they were thrombus.
No. It's not thrombus. No. This is part of the device.
It's just, yeah.
So again, from the people, the attendees, what about the gradient? Did you measure the gradient, the tricuspid?
Not yet. First, we need to really be safe that we're gonna keep the PASCAL in this position. The gradient is usually in the tricuspid valve not really an issue. At least if you place one device, you see rarely an increase in the gradients. We try at the end to be with a gradient below 3 millimeters of mercury or equal to 3. We're going to measure this in a second, as you see. But in this large valve, you hardly get to a point where you have some tricuspid stenosis unless you place several of these devices.
I think, my point in this regard is to change the position and to go a little bit more commissural. Otherwise, you have to finish up with 3 PASCAL.
Jörg, it looked like you probably had enough septal, but I guess I worry a little bit about that initial Anterior graft.
yes. Yeah.
Yeah.
So that's what I thought as well. So what I would propose first is that we're going to reopen the device now and check if we can optimize the anterior grasp a little bit.
Yeah.
I would now swing over to the anterior leaflet a little bit. And now we will.
Ihr habt kein Bild gerade. Sorry.
Now we need to optimize the imaging, and then we will try to grasp a little more of the anterior leaflet. Otherwise, we need to start all over again in this patient. I expected it to be actually a little bit easier, but that's how it is in these tricuspid valves.
But I think it's in tricuspid, it's, you know, many times it's like that because the predictability is low, not because of the device, but because of the anatomy of tricuspid, you know.
Yeah.
Yeah.
Now we raise the anterior clasp, and now you can see, I think the leaflet looks very nice on the device.
Yeah.
So I
It
would
actually
close it
looks
again.
very good. Yeah.
Close it. The clasp went down. We will look at this again, and perhaps you can continue with your discussion while we're going to do a re-evaluation of the leaflet insertion.
It really looks a little taut, her, but I know you didn't lift any. You didn't lift up the clasp at all, right? But it does look taut.
The clasp was we reclasped it. It was reoptimized.
Oh, you did. I mean, it really looks tauter.
Did.
Yeah. So it looks much tauter. So I like it a lot. And it looked like it was all the way in.
Yeah. Now I'm closing it again, and let's see if we can get a better result. Maybe we check the color first.
We have a problem here.
We still have some significant TR in the anteroceptor line of coaptation. So I think we need to start a little bit more aortic, a little bit more closer to the commissure, so that we're going to close this.
This was I meant before.
Yeah. Okay, I'm opening the device. Again, we're going to raise the clasp, and then we go more into the anteroceptor line of coaptation and start there in the more like sipping mode. Try to grasp the leaflets there.
Okay, but then to do that, you prefer to go transgastric?
Well, we need to go transgastric in a second to confirm our position, of course.
I mean, in general, I think I agree that now we have to, or Jörg has to move to the anteroseptal commissure, but nevertheless, with this device, we often saw that just trying to improve one side really yields surprising results. So I think it's always worth to do what Jörg just did and try just to optimize one side if you're not sure about it. Sometimes it's amazing how the chat disappears.
Yeah, we found the same thing, you know, just a little bit more leaflet in there and suddenly it's all gone.
Okay, geht's nach oben?
But this is a pretty big jet, you know, the jet is all along the entire commissure, so.
Well, we didn't want to start with a patient who has no TR, so we of course selected the patient who has some disease.
Bist du da, wo du bist?
Yeah.
This looks like a good orientation too.
We're not very much higher, but at least now we have both leaflets on at the same time. Let's close it both simultaneously. Okay. And before we go even further, I give it a try in this position. Let's see what the color says. It's still the same. So I need to go really significantly higher. There's no doubt about this. I reopened the device. The nice thing is that the PASCAL is so gentle to the valve, so that you don't have to fear that these multiple graspings will result in a significant leaflet damage. If you, of course, you have to be careful all the time. But the device with the nitinol component is so gentle that I think it's, at least we haven't seen a significant problem with the device. Now we close it again.
You're on. Yeah, definitely on.
Now I'm significantly higher in the anteroceptor line of coaptation. You see the tensioning on the leaflets.
Yeah, beautiful. Yeah. Yeah, I think you have that.
Now we really need to change our strategy from a more central PASCAL placement to really more like a sipping strategy down the anteroceptor line of coaptation. Here, I think at least there's only a very tiny jet, a residual jet between the PASCAL and the aorta on the left in the left image.
Yeah.
So probably this would be a good location for the first PASCAL.
Yes, let's see the color.
There's still a large jet, of course, remaining in the central part of the valve, of course.
For me, this is far better. Because
Yeah, much better.
Yeah, much better, because now you split the regurgitation, but the anterior part of the regurgitation is really tiny. So for me, with another PASCAL, you may, you know, come up to a significant reduction of tricuspid regurgitation.
Yeah. So we're going to just briefly look at the leaflet insertion, and then if we're happy, then we will release.
It's okay.
Or just here, Michael says it's okay. So we're going to release the PASCAL in this position, and with a strategy to place the next one just next to it on the more central part of the tricuspid valve.
It's beautiful.
Transgastric view.
Da kommen wir gleich. Michael, willst du nochmal transgastrisch zeigen kurz? While we are detaching the device, we're going to show you also the transgastric view in this position.
Okay, perfect.
Mm-hmm.
Very, very commercial,
Nice.
of course,
Very
but
commissioned,
Very
well.
nice.
but we have a nice leaflet insertion into the device.
Can we see the color flow here?
Color flow here, Michael?
Just for the audience, just to look.
Sure.
Here in the anterior part of the PASCAL, you don't have so much regurgitation, so you can fix it. You can fix it with the second PASCAL.
That's what we are hoping to do. Yes.
It's a beautiful example of the tissue bridge, right? Even on two-dimensional imaging from this gastric view, you really see the leaflets coming into the device, which is just perfect.
Perfect. Now, what we can go to the fluoroscopy. Perhaps briefly, you see a very stable positioning of the first device. And now we're going to exchange the device to the second PASCAL.
So, Jörg, there is a question from the audience that is, if the regurgitation after the procedure still remains significant, that this is the case, our case, do you consider to use hormone device? That's possible. Which type of device?
Well, we're going to stay with the same device with the PASCAL ACE. Due to this, as I said before, the dense chordae in the leaflets, we think that this device has some advantages compared to the P10, so the conventional size of the device?
There have been investigators that have gone ahead and combined these leaflet coaptation devices with an annular device. You know, if there's a lot of remaining regurgitation, but you know, we'll have to see, because I think he'll end up maybe with 3 devices and there really won't be much regurgitation left.
Well, that's at least my hope that we're going to get there, that we only have residual TR left. But of course, it's an option, of course, to add an annular device, an annular PAST device also after edge-to-edge repair. Now I would like to come out with my prepared device. Michael, can you show me? Here's the device in the right atrium. So I'm going to extend this from the guiding catheter in this elongated form. Now we're going to close it. Now you see it's closed. And now we will bend down to the tricuspid valve again and try to orientate ourselves just below the first device. Das ist natürlich ungünstig.
Yeah, we've had to use.
Yeah, but sorry, by fluoroscopy, you just see that I'm just inferior to the previous device. And then by echo, you also see me just in front of the tricuspid valve, just inferior to the first device. We can do the clasp check here again, briefly to identify which clasp works with each slider. So you see nicely here, this is the posterior, the septal slider, which is activated by this posterior slider. Now I will go into the valve in this little bit elongated fashion.
Can we see the floor?
Sure, in a second. In the fluoro, you see probably not a lot, but you see that I can go very gently into the tricuspid valve. Say it again, Giuseppe.
No, the floor is important just to show to the people that's the
absolutely
between the 2 Pascals. That's the only reason.
Now you see in the echo the transgastric view, and I'm now going into the 180 degrees of the PASCAL.
So one question is, so you don't make the orientation in the right atrium, but in the ventricle.
In this case, I have the first PASCAL as an landmark in my views and in my X-ray views by fluoroscopy, so I can use this in addition to now here the transgastric views that when I'm closing the device slowly from the elongated form to the 180 degrees, that I can see my orientation can correct for this without getting entangled into the valve and the cords. Gehst du dran nach oben? Now we go back in the deep esophageal view. You see we're not fully at 180 degrees.
Actually, in my personal experience, for the second grasping, I would go for transgastric, but this is just to highlight the differences, you know, between operators.
We're going to close the clasps and close the device here as well. We see a nice tensioning of the leaflets, and by fluoroscopy, It looks very, very parallel to the first one. Now we have significantly reduced the anteroseptal part of the TR. I think very nicely you see this reduction in TR. There's a central chat still remaining. And if we're happy with this location, then we have to discuss, of course, how we're gonna treat this residual TR with the third device. You see now the gradient assessed here. The heart rate is 60 and the mean gradient is only 1 millimeter of mercury. So we have no relevant gradient here. Perhaps we can go, or we can look here briefly at the leaflet insertion. I think this looks very promising.
Yeah.
I think
beautiful.
Because of
and I would propose that we're going to go into the transgastric view to look at the leaflet, to look at the tissue bridge for a second before we're going to release the device in this position. Would you agree with that?
Yeah.
Absolutely.
I was just commenting on the fact that with two PASCAL or 2 clips in tricuspid, generally you have, very frequently less than 2 millimeters of mercury of final gradient because the annulus is very large compared to mitral.
Yeah.
So the concept is a little bit different, even though, the impact of final gradient is much more important for tricuspid than mitral.
What I would like to highlight here is perhaps the anterior papillary muscle, which you have seen there again. So there's still a little bit of room in the anterior leaflet between the anterior papillary muscle and the second device. So even if we need to, perhaps we can add the color here for a second. And then this might be also a thing to discuss if we're going to need to place the next device even below this one, so that we have 3 devices parallel in the anteroseptal line of coaptation, really a sipping of the anteroseptal line of coaptation, or that we go to the posteroseptal line of coaptation. But then we might have some residual TR between the second and the third PASCAL, which I'm also fearing a little bit.
I think now it's time to review accurately in different view the residual regurgitation. Before
we will, you're absolutely right. What we're going to do now is that we're going to release this second PASCAL in this position, and then we will do this thorough evaluation to discuss where we're going to place a third device and if you can do this. Okay?
Yes, we have time. We have time. No rush.
Yeah, I think we have like 20 minutes left, correct?
20 minutes more. So I think that we have all the time in the world. Okay, please explain what you're doing now for delivery.
Now, can you what you see here is that we are can we zoom here on this part?
Yes.
Yeah, zoom in a little bit more. We are removing this this wire, this line, which works on the clasps. If this is removed, we will not be able to open the device anymore. Now what we're gonna we will remove this locking mechanism, and now we are unscrewing the device from the implant catheter. There are many turns to be made.
Can we see also the fluoro picture, please?
Not
the echo.
Yeah, this is the live fluoro. Now we're released. If you have seen this, and I will do a scene just to demonstrate you again the very stable positioning and parallel positioning of both devices. Now, as the next step, we will, as we just discussed, we'll do an evaluation in the different views of the tricuspid valve. And at the same time, I will exchange the implant catheter to the next device.
Maybe look at the echo.
Can we, please, can we see the echo on the webinar, please?
I might make a remark on our problems in the anteroseptal line of coaptation, and it is probably that I did an underestimation of the problem that we might get from this sclerotized shortened anterior leaflet. I think that I have underestimated the problem arising from it, because this is basically the problem we had with the anteroseptal line of coaptation and the regurgitation we could not get rid of. I must say this is very unusual, and I guess it's due to the fact that the anterior leaflet is damaged here. That's my opinion. I can't prove it, but it doesn't look like a standard anterior leaflet in this area. So I think that most of the problems we had with the anteroseptal line of coaptation is due to this fact. Normally, if you place a clip in the anteroseptal line of coaptation close to the center, you usually don't have a residual TR in the anteroseptal line of coaptation. This is very unusual. So I think I have underestimated the problem of this valve in this area.
Can we see the residual tricuspid regurgitation?
We can look at the residual TR, yes. We do this in this deep esophageal view, the inflow-outflow view, or commissural view. As we, you see the two devices there?
Yes, we see.
Now we add the color, please, and you see that the main chat is originating from the center of the valve.
Could you eliminate the color picture on the screen? We just need to see the echo.
Oh yeah, in the webinar, yes, thank you very much. This is better.
Okay. See, we have, you know,
maybe we go also transgastric now to look again where we can place a third device, which will then hopefully remove this residual TR. As I said, where there's still some space between the second device and the anterior papillary muscle, so this would be one option. And the other option would be, as Becky said initially, that we're going to place this third device between the posterior leaflet and the septal leaflet.
Please, let's see the color, just to understand.
The color in this view in a second. And we also need to, yes, go ahead.
I think we always have a little trouble knowing what to do with that anterior posterior septal commissure, right where that anterior papillary muscle is. We always, you know, have a gap there, and you know, again, it's you're right. It's half a dozen of 1/6 of another almost to decide whether to go on the anterior side or the posterior side of that papillary muscle. In all likelihood, my guess is if you put the third clip, no matter where you put it, that gap between the anterior and the posterior leaflet is going to have a residual jet. And sometimes we just live with that. We say, listen, it was a regurgitant orifice of like 2 centimeters squared, and we've gotten it down to, you know, 20 millimeters squared, and we're fine.
Yeah, I absolutely agree. It's with this technique, we will hardly get to a TR of 0. So there's always a small jet remaining, but this is really not a clinical problem at all. So I think what we have shown very nicely in Triluminate, even if you go from torrential to still severe, the patient will feel a significant improvement in the symptoms. Would you agree, Becky? You know the data better than I do.
100%. Just even those patients who had a single grade reduction, which was by far and away the majority of the patients, all still had significant functional and quality of life improvements. You've already brought this down really significantly. I think one more device and you'll have it down to moderate or less, I think.
Hopefully, yes. So I inserted the third device, and now we will bend down to the valve, and then we really need to discuss where we're going to place it. Michael, what do you think? Shall we go to the
I would
place?
go posteroceptal. That's what I would do.
Michael tends to do a posteroceptal.
I don't think we have enough room on the anterior leaflet anymore. And there is a small commissure scallop. I would not go for that. I would go for the posterior leaflet.
You see me preparing this already. Let me see. Perhaps we can also show the fluoro in addition on somewhere. This is possible. That you see now that the third device is just in front of the tricuspid valve. Again, I would elongate the device here so that we can very gently
Clasp test.
go in.
Could
Yes.
have changed something by using the normal PASCAL instead of ACE.
Clasp test.
Here, show, look. Say it again.
Do you think that could have changed something by the use of normal PASCAL and not the ACE?
Yes, I think in this patient, it would have been much more complicated with the conventional P10 device because of these dense chordae to go underneath the leaflets. But that would be my fear, at least. I don't know what you, Volker and Becky, what you think about this.
I would completely agree, and also I think you could not expect with one P10 device to have reduced the TR in the anteroseptal commissure. You probably would have also had to use two devices, so there's no gain from it, I think.
Yeah, I think once you also, you went into the commissure to start, it is so much denser, the chordae there. And with the wide device, you do get a little more difficulty bringing it up to, to get the leaflets captured. So yeah, I like the ACE.
It's really my favorite in the meantime. I'm more or less, I would say 95% switched to ACE compared to the
P10.
Compared to the P10.
Bist du richtig?
I think so.
Also aufgestellt?
Noch nicht ganz zu, noch nicht 180 Grad, jetzt bin ich 180. Now I closed the device to 180 degrees. We were trying to get now an image to show that we are perpendicular to the posteroceptal line of coaptation.
Yeah, looks good.
I would like to be a little bit more central if possible. Let's see if we can get there.
Yeah, that's a big papillary muscle.
Yeah, this will work against us a little bit, of course.
Yeah.
But perhaps now we're in a position which I like. So we're a little bit in a V shape to the first and the second device. Michael, what do you think?
Okay.
Okay, then we would go now back to the deep esophageal view. I have to change my fluoroscopic window a little bit. Probably I'm interacting a little bit with the RV because I have some extra systole here.
There you go.
Now it's better. Okay. Now you see, it's the posteroceptal line of coaptation is always a little bit more difficult to treat. The imaging is a little bit more difficult, and sometimes it's also a little bit more difficult to get with the device in the location where you want to be. Michael is trying to optimize the imaging for us. There are 10 minutes left for this procedure, at least for the video time. And perhaps, well, we're a little bit oblique in this view here. But now you truly see the difficulties with tricuspid interventions. It's not to get the device into the valve, but it's really for the interventional echocardiographer to get good image quality, so that we, as the interventionalists, can have some images to work with. It looks always easier, but it's really the most difficult part is the imaging.
Here we go.
Let's hope here we see it now a little bit better. It's hard to get both arms in the same view, so it's, well, we need to discuss if you're going to do an independent grasping again or a simultaneous grasp. Becky, do you have some suggestions from your point of view?
Yeah, I mean, maybe to get it more vertical, I don't know, Michael's probably already retroflexing, but sometimes that'll help you instead of a flex, but a retro might get it straighter. The other thing we end up using a lot is the, here we go, is the 3D Live NPR, but he's got it already, I think.
But transgastric is not really convincing. So
yeah, we thought about this as well.
We can see it in NPR.
Yeah. Yeah, even from here to use NPR sometimes is helpful, but I think you're going to get it.
Well, we're fighting a little bit with the views. But it doesn't make sense to rush here. I think we really need to get a good image before we gonna go ahead.
And I think that's a very important learning. I mean, sometimes it just takes 20 minutes to get this image, and you have to wait.
Absolutely.
Because if you have a single leaflet detachment or something, I mean, it can be a catastrophe, and therefore I think it's really worth to wait.
Yeah. I mean, when you think about what you've accomplished, you know, in a little over an hour, it's truly amazing. Because I think sometimes the tricuspid can take us, you know, 3-4 hours. So I'm really impressed already.
Willst du es hier probieren? Weil das Bild ist nicht.
Well, let's give it a maybe. Here we see it, the leaflet's a little bit better. I give it a try here, and otherwise what I would suggest is that we're going to give it a try with the MPR mode from the transgastric view, but this might take then a little bit longer than our planned transmission time. But as you said, as we just discussed, it doesn't make sense to really rush here just to get a result.
There is no sense to rush because the result that you have obtained so far is really promising for, you know, that third clip to finish up with the regurgitation is going to be less than 2+. Less than 2+ is the goal, because if we, you know, look at the data to illuminate, we know that when we reach out.
Posterior ist drauf, oder?
Yeah.
Posterior?
Yeah.
Michael,
Ja, Posterior ist drauf.
tu mal Posterior runter. Okay. We try to grasp the posterior now, and the septal
Oh.
is
Septal's on.
We're going to put down the septal. I'm not 100% convinced about the posterior.
Yeah, we'll have to
Yeah.
check that again.
We're going to check this in the transgastric view now, perhaps, and in several other views, or we need to optimize the posterior. The septal, I'm pretty confident, is
Yeah.
nicely on.
I'm not sure what's going on with the posterior. We have to check that from transgastric, please.
Maybe we're probably also a little bit disorientated, rotated with the device. That's what I'm assuming. Although
Looks pretty.
it's not that bad. The orientation is not that bad. It's now we're trying to see if we have enough posterior leaflet immobilized in this transgastric view.
Yeah, I'm worried you just have some cordy, maybe
Yeah.
maybe nothing.
So maybe we're gonna go back now and try to grasp a little bit more of the posterior leaflet before we're gonna close the device.
And this is also I think, a very important learning. Exactly at this spot, this situation occurs quite frequently in our experience, that you only have chordae in there. And it's very important to reassess the situation then.
Yeah. Yeah, probably there were only chordae as we just see it. It's very difficult to grasp more of the posterior leaflet here.
Yes.
I tried to swing over, but like in the Tarzan maneuver to get more of the posterior leaflet. But now we're probably too close attached to the septal leaflet so that it's going to be impossible.
Yeah, it was
Yeah,
such
so
a,
I would probably have to release the septal leaflet again. And then we need to start all over again in this position.
There are 3 minutes left, so I think you don't have to rush too much. In the meanwhile, you're working. Let me, in 2 minutes to deliver some take-home messages related to this webinar. First of all, I would like to share with the audience that the tricuspid transcatheter valve intervention are under clear development.
Ich mach beides auf.
The initial results seems to be very encouraging in terms of feasibility and in terms of benefit, both in terms of mortality and morbidity within 1 year. As we know also by the Triluminate, when we get a reduction of less than 2+ in final tricuspid regurgitation, we have a 70% reduction in terms of death and heart failure at 1 year. Second point that I would like to share
Soll ich
is
transgastrisch gehen?
of the heart team. At experienced heart valve centers, is mandatory to succeed.
Jetzt ist drauf, posterior ist drauf.
The third point is the importance of imaging.
Posterior ist drauf.
Echo and MDCT, that might be the preferred technique to use due to the high spatial resolution.
Yeah.
And finally, today we have transmitted about the PASCAL ACE that may have some advantages over the other device that we have, because they may reduce the leaflet stress, increase of at least 20%.
Du bist jetzt nah am Rand, ja. Musst ein bisschen clockwise rotieren.
Leaflet grasping, and finally may reduce the entanglement of tricuspid subapparatus systems. So having said that, I would like to thank Becky. I would like to thank Rudolf, and mostly the team from Munich that is York and his team for this outstanding demonstration of the feasibility
Of the
of
difficulties.
transcatheter patients. So you have to take in mind that all the time has been no more than 1 hour. So actually this procedure, sometimes if you look at the studies, takes more or less 160 minutes. So we were very fast, and I think for the sake of patient and the final result is better you to take your time, not to rush, and to complete with the final result that is going to be less than 2+ for sure. Last comment from Rebecca and Rudolf before saying hello and to conclude this webinar.
Yeah, I couldn't agree with you more about all your take-home messages. I do think that the skill that you've seen Michael exhibit with the imaging is not just it has to be taught and it has to be learned. And so as we are training our new interventional imagers, I think it's important to realize that it's a whole different skill set.
Yeah, I mean, I think
we're gonna Volker, just 1 second before we're gonna need to go. Perhaps we were able to grasp now the leaflets, and now we see at least a further reduction of the TR. There's still some jets left, but I think overall we have now in this posteroceptal line of coaptation also
That's
a very
beautiful.
nice grasp with a nice reduction. So without saying some additional words, at least from my point of view, I would like to thank you all for participating. And then now, Volker, you can have your final words.
Thank you. Thank you very much from all of us. Okay.
nothing to add.
And thank you for all the people that were fully engaged during this webinar from home. Thank you. Stay safe and stay strong from our side. Bye-bye.
Thank you so much. Stay safe.
And stay strong. Bye-bye.
And bye-bye. Thank you so much. Bye-bye.
Bye.